I wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been and still is the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit River. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this land. As a reminder, please keep your microphones on mute. We will start with Dr. Alana Miller, PGY5 Geriatric Medicine, a veteran at Journal Club presentations, presenting on the diagnosis of non-consensus transient ischemic attacks with focal negative and non-progressive symptoms of population-based validation by investigation and prognosis. So with that, Alana, please feel free to unmute and share your slides.
Good morning, everyone. Thank you, Dr. Gandel. As Dr. Gandel mentioned, my name is Alana Miller. I'm a PGY5 in geriatric medicine, and today I'm going to talk to you about a Lancet journal article called The Diagnosis of Non-Consensus Transient Ischemic Attacks with Focal, Negative, and Non-Progressive Symptoms, Population-Based Validation by Investigation and Prognosis. I have no conflicts of interest. And my objectives today are to review the literature on TIAs and management, to review the study's methods and results, to provide critical appraisal of the study and initiate discussion on its implications. Some background: 20 to 25% of ischemic strokes are heralded by TIAs. The risk of stroke is up to 10% within 7 days of the TIA, and this risk increases up to 12% at 90 days. Stroke is the leading cause of disability and the third leading cause of death in North America. And symptoms of TIA, if recognized, provide a critical opportunity to prevent stroke. So we have good evidence for stroke prevention after TIA. The Express study in 2007 demonstrated that patients with TIA or minor stroke treated with urgent assessment by a stroke neurologist and initiation of aspirin, clopidogrel, statin, and perindopril plus minus indapamide compared to usual care reduced the 90-day risk of recurrent stroke compared to control. Also, the Chance and Points studies studied patients with high-risk TIA and minor stroke and found that initiation of aspirin and clopidogrel within 24 hours or 12 hours in the Point trial was superior to aspirin alone in reducing the 90-day stroke incidence. But diagnosis of TIA can be difficult. It's a symptom-based diagnosis, as often there's no acute ischemia on brain imaging. It relies on the patient's ability to communicate symptoms and the clinician's ability to interpret those symptoms. So actually, TIA remains a highly subjective diagnosis. And the inter-observer agreement for TIA diagnosis is moderate at best. A 2019 retrospective cohort study identified 254 patients in the emergency department diagnosed with TIA. The patients were either admitted for workup or referred to TIA clinic, and the final diagnosis was verified by 2 stroke neurologists. The 2 stroke neurologists found that admitted patients were diagnosed in 60% of the time, and patients seen in follow-up clinic were misdiagnosed 46% of the time. And then a 2010 observational study evaluating the concordance of TIA diagnosis by 3 stroke fellowship trained neurologists. They were presented with 55 patients, history and physical exam findings, and they determined the likelihood of TIA based on a scale. On a 2-point scale, likely TIA versus unlikely TIA, their concordance was 0.72, and 100% agreement is concordance of 1. On a 3-point scale, likely, possible, and unlikely, the concordance was 0.56. And on a 4-point scale, their concordance was 0.47. So how can we improve our diagnosis of TIA? There are some tools. This is one that I used in my training called the ABCD2 tool, looking at age over 60, blood pressure 140 over 80, clinical, which is neurological deficit, either hemiparesis or speech problems without weakness, duration of symptoms, and diabetes. But a study in the CMAJ in 2011 found that the sensitivity of an ABCD2 score over 5 was only about 30%. And an ABCD2 score of more than 2, the sensitivity improved to 95%, but the specificity went down to 12.5%. So overall, their accuracy of this score is poor. So the tool is not great. What about definitions? The National Institute of Neurological Disorders and Stroke, NINS, is a group that was created by the US Congress in 1950, and it was developed by expert consensus to aid clinical diagnosis and research recruitment. And the TIA definition, according to this group, is a brief episode of focal brain function loss, presumably due to ischemia, that can usually be localized to a brain region supplied by a single vascular system, left or right carotid or vertebrobasilar system. And other guidelines, such as the AHA guidelines, refer to these definitions. So the NINS TIA definition includes what's called classic TIA symptoms, which are motor weakness, dysphagia, sensory loss, hemianopia or quadrantanopia, monocular vision loss, vertigo plus, dysarthria plus, and ataxia plus. And plus refers to any other TIA symptom. But notably, the NINS definition excludes non-consensus TIA symptoms. And these symptoms are vertigo only, defined as new, non-recurrent, isolated vertigo, not precipitated by head movement or trauma, and without associated ear pain, tinnitus, or hearing loss. Ataxia only, which is unsteadiness of gait. Diplopia only, which is isolated binocular double vision without an obvious ocular or neuromuscular cause. Dysarthria only, bilateral decreased vision only, and single segment sensory loss only. And why are these symptoms excluded? It's because often they have a non-vascular cause. However, they can have a vascular cause. And the examples are this history of a 59-year-old man with 30 seconds of slurred speech, which is considered a non-consensus TIA because it's dysarthria only. He has a normal physical exam. And on the right hand side of your screen is an MRI, diffusion weighted image, which is great for visualization of acute ischemia. And it shows restricted diffusion in the right post-central gyrus. And then in this paper, they also give this example, which is a 64-year-old man with sudden onset double vision lasting 30 seconds. He could see normally if he covered either eye. He saw an optician the following day and no abnormalities were detected. So this is categorized as diplopia only. So it's a non-consensus TIA. And you can see that in the MRI, he's got restricted diffusion in his right thalamus. That's the bright spot in the center of the scan. And thank you to Dr. Tangway, who helped explain how this could happen. It's thought that this patient likely had a posterior brainstem lesion that embolized to the right thalamus. And therefore, this actually is considered a non-consensus TIA. So the objective of this study was to determine the incidence, clinical characteristics, investigation, and prognosis of non-consensus TIAs. The study design is a prospective population-based study in Oxfordshire, UK, and it's part of the Oxford Vascular Study, or the OSC-VASC study. The population is 92,728. And this population is unique because about 99% of residents register with primary care, which holds a lifelong record of all consultations and investigations with primary and secondary care providers. The inclusion criteria is Oxfordshire, UK residents with sudden onset transient neurological symptoms who sought medical attention in primary or secondary care between April 2002 and March 2018, and exclusion or cases where initial brain imaging revealed a brain tumor, subdural hematoma, or vascular malformation. To identify all patients with sudden onset neurological symptoms, investigators visited John Radcliffe Hospital daily, and it's the only secondary care center. They identified patients who died prior to hospital arrival, identified patients attending TIA, stroke, and eye clinics, searched hospitals, diagnostic records, and neurovascular imaging. They searched primary care computer records for vascular diagnoses. And so the intervention, all cases were reviewed by the study's senior neurologists, and the cases were classified prospectively, usually on the day of ascertainment, as non-vascular, so for example, migraine, aura, or seizure, stroke, classic TIA, or non-consensus TIA. And the events were classified by likely vascular territory, anterior, posterior, or uncertain. And to capture late or non-presenters, patients were asked about transient neurological symptoms or stroke-like events in the preceding 90 days. Investigations were blood tests, brain imaging such as CT brain and carotid Doppler ultrasound. MRI brain was done after 2009, or MRA of the cerebral and extracranial vessels, ECG, and vascular imaging. Echo after 2011, 5-day Holter monitor, and bubble Doppler to detect foramen ovale. So all patients with TIA or minor stroke immediately started antiplatelet therapy, either an aspirin load or clopidogrel load or both, and long-term antiplatelet therapy, which was aspirin or clopidogrel 75 daily, anticoagulation if appropriate, blood pressure lowering therapy, which was perindopril plus and minus indapamide, and lipid lowering therapy, atorvastatin. And patients who were first seen in the emergency department before study referral were managed according to the treating doctor. So outcome was recurrent stroke, and confounding factors they evaluated was timing of presentation to medical attention and early antiplatelet therapy. Follow-up was done in person at 1 and 6 months and 1, 5, and 10 years. And if a patient moved, follow-up was done by the phone. And if a recurrent stroke occurred, patients were seen by a study doctor and cases reviewed by a senior neurologist. So baseline characteristics. Patients with non-consensus TIA versus classic TIA were younger at about 69 years versus 73 years. And patients with non-consensus TIA compared to classic TIA had lower rates of AFib, lower rates of CAD, lower probability of having a previous stroke, and less likely to be taking antithrombotic therapy. The patients with classic TIA were more likely to have intracranial or extracranial arterial stenosis in the anterior circulation, whereas non-consensus TIAs were more likely to have stenosis in the posterior circulation. So results. From 2002 to 2018, there were 570 patients with non-consensus TIA. And of those, 99 had a recurrent stroke, 1,021 had classic TIA, and 199 had recurrent stroke. 1,287 had minor stroke, and 279 of those went on to have recurrent stroke. So the incidence of non-consensus TIA is lower than classic TIA, 51 per 100,000 compared to 92 of classic TIAs. And the 7-day risk of stroke from the index event was statistically lower for non-consensus TIAs compared to classic TIAs, which was about 7% compared to 9%. But the 90-day risk of stroke and the 90-day risk of stroke and cardiac events were statistically non-different. So they were similar at about 10% for 90-day risk of stroke. The non-consensus TIA patients were less likely to present on the day of the event compared to classic TIA. 59% presented on the day of event, whereas 75% of classic TIA patients presented on the day of event. And after adjusting for the timing of presentation, the 7-day adjusted hazard ratio was similar for non-consensus TIAs versus classic TIAs at actually 7-day risk, 90-day risk, and 10-year risk of a stroke. The stroke risk after seeking medical treatment was lower for non-consensus TIAs compared to classic TIAs. So the 7-day risk of stroke after seeking medical treatment was about 3% for non-consensus TIAs and about 6% for classic TIAs. And there are statistical differences between the 90-day risk of stroke after seeking medical treatment as well. 3.6 versus 7.1, and the 10-year risk of stroke. After seeking medical treatment, the risk of stroke is statistically similar for non-consensus TIAs and classic TIAs. Non-consensus TIA patients were less likely to be started on antiplatelet therapy. 26% of patients with non-consensus TIAs were not started on antiplatelets compared to 11% of patients with classic TIAs. And if patients were not started on antiplatelets, they had about 10% risk of 90-day stroke. And if patients with non-consensus TIAs were treated with antiplatelets, they had a 1.3% chance of 90-day risk of stroke. If they were not started on antiplatelet therapy, their risk of stroke was about 10%. The 10-year risk of major vascular events and intracranial hemorrhage was not statistically different for non-consensus TIAs and classic TIAs. It was about 30%, and the 10-year risk of intracranial hemorrhage was about 1 to 2%. So the summary of results is that patient with non-consensus TIAs compared to classic TIAs from the time of index event have a lower 7-day but similar 90-day risk of stroke. They are more likely to delay seeking medical attention. And after adjusting for their delayed presentation, they have a similar 70 and 90-day and 10-year risk of stroke. and they are less likely to be prescribed antiplatelet therapy, and they have a similar risk of 10-year risk of major vascular events. So the clinical implications of this study, according to the authors, are, since this is the first study focusing on non-consensus TIAs, this study can improve the reproducibility of clinical diagnosis of TIA, inform guidelines on TIA diagnostic criteria, prevent falsely reassuring patients with non-consensus TIA because their prognosis is not benign, can redefine TIAs so that patients with non-consensus TIAs are included in clinical trials. It can aid in educating the public to seek medical attention after sudden onset neurological symptoms. And it can inform the need for brain imaging capacity by as much as 50% for non-consensus TIAs. So the critical appraisal, are the results valid? Was everyone included who should have been? Yes. So there was near complete identification of patients presenting to medical attention with possible TIA or stroke, but they were unable to capture those with index TIA who did not seek medical attention and did not have a subsequent stroke. Were methods to determine outcome objective and consistent across the cohort? Yes, because the outcome was strokes, and these are identified on imaging. The timing of the presentation and whether the antithrombotics were prescribed are objectively determined. So what about the classification of non-consensus versus classic TIA? Was it objective? I don't think so, no, because all cases were reviewed and classified by one senior neurologist. And we know that inter-observer agreement for TIA diagnosis is moderate. There's an element of subjective clinical judgment to interpret the symptoms despite the pre-specified syndrome descriptions. And another issue is that the events were classified according to their first presentation, but patients subsequently had multiple events of different types. So for example, somebody could present with a classic and then go on consensus TIA. So was the follow-up complete and sufficiently long? Yes, so the follow-up occurred for 10 years or 17,000 person years, and most was in-person follow-up. But there was insufficient data to report rates of recurrent individual non-consensus syndromes. And they didn't report any data for the TIA mimics and non-vascular diagnosis. So how can I apply the results to my patient care? Are the patients in the study similar to my patients? In some respects, yes. So most of the study patients were over 65 and had a broad range of social deprivation. But the population in Oxfordshire, UK is mainly white European, and my patients are more diverse. And do the benefits of investigating and treating non-consensus TIAs offset the risk of exposure? Yeah, I think they do. The diagnosis of non-consensus TIA is important because if you start secondary prevention, you can prevent a stroke. The risk, of course, is that there's an increased need for urgent imaging. And then false positive diagnoses of non-consensus TIAs could subject the patient to a lifetime of secondary prevention medications and all the risks associated with those. And then, of course, there's increased exposure to radiation. So the CT brain is equivalent to 20 chest x-rays in terms of radiation. So is this study practice changing? I don't think so. When diagnosing TIA, most physicians, I believe, will consider the symptom, monosymptomatic or not, and the vascular territory. And physicians are not categorizing symptoms according to the NINS TIA definition. But it is very important to recognize that patients with non-consensus TIAs are at high risk of recurrent stroke, and that secondary prevention should be initiated at diagnosis. I think for me, this study emphasizes the importance of good history taking and neuroanatomy. So the bottom line is that patients with non-consensus TIAs are at high risk for recurrent stroke, similar risk to those with classic TIAs. Investigate urgently and treat early with secondary prevention. And I'm free to take questions.
Thank you very much, Alana. Beautiful presentation, very well delivered. I'd like to open it up to questions to the audience. Feel free to raise raise your hand or put in comments or questions in the chat box. Go ahead, Murray.
Yes, Alana, I would echo what Dov said. You presented very clearly, and for me, who is really a neurology buff, and dementia is something that I have a passion for, and I started as a physiotherapist. Many knows I was accepted in neurology and turned it down for geriatrics. I had never heard of this concept, and I find that you described it quite clearly, and for me, it just raises awareness, particularly with regard to brain imaging, which you made a very good case for. I think the challenge we have in our healthcare system is, getting the imaging in a timely way for someone who would have non-consensus TIA symptoms. I don't know within the audience, do people would refer such patient to the rapid TIA clinic?
Yes, I spoke to Dr. Tangway about this, and he said that at UHN, if a patient with suspected TIA, whether that be non-consensus or classic, it can be referred to their stroke prevention clinic within 24 hours, and they have MRI spots dedicated to that clinic. And so they're able to access urgent imaging. In the community, I think it would be a much different story and very challenging to get that imaging.
Thank you. Thank you. Marjorie Hammond has a comment in the chat about strategies you would consider for educating emergency physician MDs because they see these people first. I had a question about the critical appraisal. Your first validity question is, do you think that all patients were captured? And so when I read the methods, I saw that this was primarily based on primary care doctors referring patients who presented with new sudden onset transient neurological symptoms. So there was a degree of physician, as you say, subjectivity and interpretation to say that I think this is a vascular event and referred this patient on. Do you think that the patients with similar symptoms that the primary care physician did not refer to this clinic may have had something to add in terms of the final risk determination?
Sure, I suppose, those patients who were presenting to their primary care physician would definitely have to be articulate enough to recognize this abnormal event. And of course, symptoms of TIA are transient. So, they resolve usually by the time they see their primary care provider. So I'm sure that some patients were not captured in that pathway. And then, of course, the reliance of the family doctor to refer them to the neurologist also is one method to lose more patients. But they did emphasize that the primary care physicians had ongoing education and reminders to refer. And this is a group of primary care physicians for years who've been doing it. Like, there's many studies that are covered by this population, including the Express study that I talked about in 2007. So it's not perfect, you're right. Thank
you. Yeah, I worry about those patients who the primary care physician may have decided did not deserve to be referred, but possibly had those neurological symptoms.
Mm-hmm.
Any other questions from the group?
Just a comment, you can imagine that this is a risk factor for dementia, such that really a big public health concern. And I think, to my mind, raising awareness to this condition and the benefit of secondary prevention would be very important.
And thank you, Ed. Lastly, Alana, I wonder if you saw any analysis stratified further by age. And so the paper does raise the suspicion that your index of suspicion should be higher with these non-consensus symptoms. Was there further stratification based on age?
Not that I saw or focused my attention on.
Thank you very much. Any other comments? Perhaps do you want to respond to Marjorie Hammond's question? Do you have any strategies you would consider for educating emergency room physicians?
I think one way to do it would be education, presenting this paper to the emergency physicians, and the reminders, similar to what they did for the primary care doctors in Oxfordshire, UK. They could roll out a similar ongoing education for those doctors, so that these people do get the secondary prevention that they need to prevent strokes.
Great. We have a couple of more minutes if anybody would like to share comments or questions. If not, we will proceed to the next presentation. So thank you very much, Alana, for again, a excellently delivered presentation and interesting article. We'll move on to Dr. Anam Majeed, PGY3 Care of the Elderly resident physician, presenting at Journal Club, I believe, for the first time. So a warm welcome to you. Thank you. The effects of music therapy on cognition, psychiatric symptoms, and activities of daily living in patients with Alzheimer's disease. Look forward to this. Please feel free to unmute and share your slides.
Okay. So, share screen. Okay, so I chose to do my presentation on music therapy and Alzheimer's disease. It was just out of a broader interest about non-pharmacological treatments that we can do for some of the symptoms in dementia, which really interests me. So I have no disclosures, being a resident, obviously. And my aim here was to critically appraise this RCT from 2018 relating to music therapy. And just more thought around non-pharmacological treatments for BPSD, as well as cognition in Alzheimer's dementia. So the way that I found this was I was in PubMed doing searches, and I found a few systematic reviews, meta-analyses, and then I decided upon this article, although it is from 2018, because it had a larger sample size and was done, it seemed like a more of a comprehensive study. So it's called The Effects of Music Therapy on Cognition, Psychiatric Symptoms, and Activities of Daily Living in Patients with Alzheimer's Disease. This is done at the Beijing Institute for Brain Disorders in Beijing, China. And there's a lot of institutions involved, Beijing Geriatric Hospital, as well as the Central Conservatory of Music in China. So this is just a little slide on the principal funding for this study, which seems to be state mandated. So basically, the inclusion criteria was quite broad, 65 years and older, with a diagnosis of probable Alzheimer's disease based on the subsequent criteria. So basically, they used the National Institute of Neurological and Communicative Disorders and Stroke and the Alzheimer's Disease and Related Disorders Association. It's really long. This long name. So the exclusion criteria was patients who experiencing hearing difficulty, even with hearing aids, so hearing loss, obvious difficulty in communication, and any other conditions which may disturb assessments or interventions which they did not specify. They randomized groups into 3 categories: people receiving music therapy, people merely like reading lyrics, and a blank control group receiving no other interventions. They were also taking medications for dementia during the study, as well as atypical antipsychotics. So basically, this is just a table to show that they further stratified these patients into mild, moderate, and severe Alzheimer's dementia. So they created 3 separate groups to analyze the data, and they did this with the clinical dementia rating scale. So this was sort of like a random allocation. And the controls where there was no significant difference in age, gender, education level, and the type of medical treatments these patients were receiving. This is just a slide on the dementia rating scale if people want to take a look at how they assess that. It was randomized, and participants were enrolled by dementia specialists, which again, they did not specify what that meant. They used a research assistant to randomly allocate these categories. And then they specified the outcome evaluators and data analysis were blinded to the group assignment. But obviously, it was difficult to blind the patients to the type of therapy they were receiving. So group A, for music therapy, what they did was they had them sing familiar and favorite songs, which they loved in their 20s and 30s. They're encouraged to sing, but when they failed to sing, they were allowed to listen to music. And they basically said they were listening to classical and soothing songs. So did not, again, specify what those were. Group B just read lyrics of familiar and favorite songs from their 20s and 30s. And group C had no special interventions or routine medical treatment. So they did this about twice a day for at least 30 to 40 minutes with 5 to 6 participants. And yeah, twice a day. So this is just another slide that's kind of going over the participant flow and the methods of how they did this study. So the way that they did the assessments was they did 3 assessments. They did one at what they called T0, which was prior to any intervention. The second assessment was 3 months after the start of intervention, T1. And the third assessment was 6 months after the start of intervention, T2. And they further did a 3-month follow-up after that just to see how long this effect lasted. They said that the data was collected by specially trained medical team of doctors, nurses, and medical students. And they did an internal standardization test to just see that there was consistency in the way they evaluated it. So this is just a brief slide. I'm sure many people here are familiar with a lot of the cognitive function assessments and other tools that are used, subjective tools. The MMSE was one. There's quite a broadly used WHO UCLA AVLT assessment, which evaluates short-term and long-term memory. They used a semantic verbal fluency test of some kind of version that a lot of people use in geriatric departments. They used the neuropsychiatric inventory, NPI, to address symptoms of neuropsychiatric distress in Alzheimer's patients, as well as related caregiver distress. And that kind of just goes over some of those factors. A higher score in the NPI means that there's more psychiatric symptoms. So this is just a little bit highlighting these 2 particular tests, if you want to see. So for the WHO UCLA AVLT, subjects are asked to recall a list of words. And they try to find words that are kind of recognized in a variety of cultures, according to them. And then semantic verbal fluency, where subjects are given 60 seconds to produce as many words as possible within a specific category, such as animals. So they're quite basic tests. And this is the NPI and the neuropsychiatric inventory. I just kind of put that in there. They said that while they had the caregiver doing the assessment on the patient, they also had the caregiver then try to put a degree of distress that they themselves were experiencing, and then they kind of summed that score. The activities of daily living assessment was measured by the Barthel Index, and this is just kind of this is quite familiar to a lot of nursing staff and other healthcare providers. Higher scores equal greater independence. So basically their overall aim was to evaluate the extent of the effect that music therapy has on language function of Alzheimer's patients. Primary outcome was the verbal fluency test score. Secondary outcome was evaluate the changes in the behavioral and psychiatric symptoms of dementia, which they used the NPI to evaluate. So this is just a brief slide on statistical analyses using one-way ANOVA, and then how they kind of just progressed along that pathway to analyze this data. Value of p less than 0.05 considered statistically significant. So the results. So during the study period, 10 out of the 298 participants withdrew. So subsequently, there was only 288 participants analyzed. And then in group A, because the intervention was singing songs, 89 of the 97 patients were able to sing these songs, but 8 patients with severe dementia were unable to follow the pace of therapy at times. So this is just a primary data table that goes over their results without being differentiated or stratified into the severities of dementia. And basically what they found that the only significant difference they could see was in the verbal fluency test and the NPI. So there was significant difference between the 3 groups with the verbal fluency test at 3 and 6 months. Group A and B scored higher than group C, meaning the interventions scored higher than no intervention, but there was no statistically significant difference between singing and reading lyrics at 3 months. And there was no statistic difference between being group C at 6 months, but having the patients sing did show some difference at 6 months. Now the NPI, there was a significant difference among 3 groups at 3 months. Group B did better than group C with no statistically significant difference between the singing and reading lyrics at 3 months. And then the people who were singing did better than the other groups, but there was no statistically significant difference between those people who were reading lyrics and had no intervention at 6 months. And then they go down further to break this down into mild, moderate, and severe. So this was just the mild Alzheimer's patients. Again, the verbal fluency test did show significant differences between the 3 groups at 3 months. Both interventional groups scored higher than the one with no intervention, but there's no difference between reading lyrics or singing at 3 months. And then, but what's interesting is that group A, where there was singing at 6 months, did show improvement. And then the WHO UCLA EVLT score, it shows significant difference among the 3 groups in immediate recall and delayed recall at 3 months. In 6 months, there was really no difference, but at 3 months, you could see that the people who were singing did better than the people who did not have that intervention in immediate and delayed recall. So this is moderate. So moderate, they're basically the only results they did see was in the NPI. The people in group 8 scored lower, so they did better than the other 2 groups at both intervals, but this result was not statistically significant. They do point out that the caregiver distress scale that was done at the same time, there were significant differences among all 3 groups at 6 months. The people who were doing singing did better than the other intervention. And then we move on to severe Alzheimer's. So again, in severe Alzheimer's, the only differences they could see were in the NPI assessment. And there was statistically significant differences among all 3 groups at 3 months. So the people who were doing the singing were doing better in the report of the behavioral and psychological symptoms of dementia at both 3 and 6 months. And again, in the caregiver distress scale, there was quite a significant improvement with group A. So with discussion of this, according to the authors of this article, with mild Alzheimer's dementia, music therapy has a positive effect on the ability of immediate and delayed word recall. This effect did not last longer than 3 months after the intervention was completed. So they sort of come to this conclusion that continuous music therapy would be beneficial in the long term. And in a clinical setting, short versus long auditory stimulation with music were shown to improve both category fluency in a verbal fluency task in older people with or without Alzheimer's disease or Alzheimer's dementia, and speech content, as well as fluency in patients with dementia. Verbal fluency test scores of patients with mild Alzheimer's was higher in the music therapy group than the other 2 groups after 3 months. And this effect lasted 3 months after the intervention was completed. With music therapy, one of the major takeaways that they came to is that it was quite helpful in controlling BPSD symptoms in patients with severe Alzheimer's. and reduce psychiatric symptoms as well as a caregiver distress for patients with advanced dementia. They also brought up these 3 studies that were done much earlier to just say that it was kind of like a similar result. So conclusions, this is a randomized controlled study with 288 participants of Alzheimer's dementia exploring effects on memory, language, and psychiatric conditions and activities of daily living in patients with different severities of Alzheimer's. Music therapy enhanced memory and language ability in patients with mild Alzheimer's and reduced the psychiatric symptoms of patients with severe Alzheimer's as well. And also like it decreases the level of distress encountered by caregivers. And they also came to the conclusion that training sessions of singing the songs are more effective than just reading lyrics. So according to the authors, limitations, they had 2 limitations, which I found kind of interesting. They did not take participant familiarity with music into consideration in study design, and the ability to sing was not assessed. So none received professional training, which I thought was kind of funny because what if they're all terrible singers? When I did the critical appraisal, there was a few things that jumped out to me. Obviously, these types of studies, this type of topic is very hard to assess. And there's quite a few holes to do like a very proper appraisal, like a proper study of this. So there's a lot of methodological issues. So example, for sample size, there's problems with participants leaving. There's problems with patients being unable to follow therapy when they have severe dementia. And it's unclear if the alleviation of the BPSD symptoms are due to the music or just progression of the disease, natural progression of the dementia. There's caregiver bias in reporting. So, if somebody's familiar with somebody they're continuously assessing, that's an issue. The confounders are also there's social interaction. So it could be that just having a group of people together in a room really helps, like the socializing. They could have increased the length of intervention. They didn't really discuss the post 6-month length assessment in a lot of detail. This is an older study for our uses. It was conducted from 2014 to 2016. And then again, it's difficult to standardize how subjectively how you would diagnose Alzheimer's dementia. You can't really double blind patients who are aware of what therapy they're receiving. And then the other thing, a consideration I was thinking is there's really not a lot of these studies that have imaging that, to show any significant changes, although that's not 100% reliable. And then just some other considerations with subjective types of interventions like this, that not everybody finds the same type of music stimulating. And especially for older people, there's a lot of social connotations to things like this, like political, patriotic songs that can sometimes dredge up not nice memories. And then they had mentioned some things like the dementia specialists that they did not really give a lot of background information of who these people were, where they were trained, what their other background was. So I'm sure there's a lot more limitations. These are some of the ones that I found that's typical, not only of this study, but many other ones. So future considerations and thoughts, I just find that the topic of non-pharmacological intervention very fascinating. And I thought it's just a way to stimulate more ideas within students and learners and faculty of being more creative, using art, being more patient-centered of what our patients liked in the past, what they did not like, using technology, but also using nature. So not just, trying to find more unique ways of treating our patients. And then before the question time, if there's time or you think it's appropriate, there's a documentary film I was watching the other day because I'm really interested in this topic, and they sort of explore music in Alzheimer's patients. This was just like a little trailer. I don't know if there's a lot of questions or if you'd be interested in watching this.
Go ahead, you can share.
Yeah.
What do you think of music? My heart belongs to music. I love it. Have you ever had music just hit you in a place that immediately brought you to tears? Music has that power. Music connects people with who they have been, who they are in their lives. Because what happens when you get old is all the things you're familiar with and your identity are all just being peeled away. We're going to do another
healthcare system imagines the human to be a very complicated machine. We have medicines that can adjust the dials. Blood pressure, oh, turn that down. Blood sugar, oh, turn that down. We haven't done anything to touch the heart and soul of a patient.
One resident that barely opened her eyes, she didn't respond. Knew her for 2 years. Once we put the iPod on her, she started shaking her feet. She started moving her head. It was amazing.
Music has more ability to activate more parts of the brain than any other stimulus.
Who am I? Who am I? I'm your daughter.
By exciting or awakening those pathways, we have a gateway to stimulate and reach somebody who otherwise is unreachable.
It can't get away from me if I'm in this place.
Takes me back to my school days. Oh God, that's beautiful.
Does it make you happy to sing for us?
Yeah. Don't cry.
Every human being needs stimulation from the outside, from little babies to old people.
American culture is wrong. There is actually life beyond adulthood. There's the opportunity to live and grow and become elders. The aging that we experience holds in it very important learnings and lessons. There is no pill that does that.
Oh, thank you so much.
Okay, so the tears of joy. Yeah. I thought you were going to grow wings.
I was trying.
Thank you very much, Dr. Majeed, for an excellent presentation. The rationale and reasoning and very powerful imagery certainly resonates with me. I'll take this moment to open it up to the audience for questions or comments. I have a few questions on the some of the critical appraisal and the randomization, but we will open it up to the audience first. Go ahead, Murray.
This was wonderful. It was moving. One thing that I think was not maybe in the study is that music has been shown to stimulate movement, such that when people sing and are engaged with music, it's not just the verbal part of the brain that's activated, but there's actually spontaneous movement that can get initiated, as was revealed in your trailer. So it would have been nice on the study to have a measurement of the activation, physical activation, as we know that with exercise and activation, that also has an impact on cognition and in a management of BPSD. Thank you for this excellent presentation.
Thank you.
Thank you, Murray. John Murata has a comment in the chat box. Thank you for a link on a startup and a reference to the Canadian Conference on Dementia a few years ago had a special session on this topic, and the call to revisit it, given the issues with BPSD, medication appropriateness, particularly in long-term care. So thank you, John, for that link. We will check that out. Any other questions or comments? And Dr. Carol Cohen reminds everyone of the iPod project available from the Alzheimer's Society. Personalized music iPod and headphones available. Also wonderful Tony Bennett profile on 60 Minutes recently. Is that iPod project still available?
As far as I know, yes, Dov, but I haven't referred anyone in the last couple of months.
Yeah.
But I'm pretty sure it's still available, free of charge, personalized.
And certainly the barrier to this intervention just at home is fairly low if the Alzheimer's Society program is not available. Deborah Brown says, excellent presentation. Perhaps Dr. Majeed, I have a question about the randomization. So were you satisfied with the randomization in terms of the process that they described? And secondly, if you look at the numbers, I would offer that the sample size as a whole is not very big. And generally, we see some imbalances in groups post-randomization with smaller samples. And it appears to me, and I wonder if the methodologists on the line would say or offer that perhaps based on the eyeball test, the randomization looks almost too perfect.
Yeah, that's another one of the issues with studies that are coming out of, I guess, a more state-controlled. I mean, it's a different country, so, and it was it's heavily funded by the government. And there's a lot of different parts of government institutions involved in this. It did appear a little bit, it just appeared a little bit too like on the nose. The interesting thing is when you have people with more advanced dementia, they also have other medical conditions and they may not be able to participate in the study, so they're not accurately represented. And then there's the other issue of them not being able to just not participate in the intervention. It may be disturbing to them, they're not able to communicate. So that they're not being accurately represented. So yeah, I'm not, to be very honest, I'm not exactly, I went through a lot of the different studies mentioned in statistical analyses that are done more recently and in different parts around the world. There was like 50 people, 70 people. So I kind of just honed in on this one because there were more people and I just wanted to see if that might contribute, but there's definitely other limitations.
So that was a little concern. And the other aspect sometimes about the non-pharmacologic measures is the control group. And so I wonder if you have any comment on the control group in this study. And I wonder if they described perhaps just the time spent with the individual based on singing, reading the lyrics, and whether there was any type of interaction with the control group, simply time spent.
They didn't mention that, like on my reading of this, they basically just were like, it's a blank control group. So you kind of just think, did they take a bunch of people, put them in a room and do nothing? Like that seems concerning. Or did they just not, like, they just followed them without any intervention? But then of course, there's different types of things like family visits, social activity, that kind of thing that confounds it. It's also kind of an ethical issue if you take people and you completely deprive them of any type of intervention that's non-pharmacological. Like, is that really something for the purposes of a scientific study? But they didn't really mention that.
I like this. Oh, there we go. Gary has his hand up. Go ahead, Gary.
Thanks very much, Anam. So Dov, just to get back to your point, I mean, the concept of active control is well recognized, particularly with these types of studies. So I would agree with you that most would want to at least control for the social interaction. And certainly one would, in a high quality study, expect to see that. And then when you start getting into the levels of severity of dementia, which clearly those groups are very different, the sample sizes start getting really small. And I have some difficulty trying to understand the choice of outcome measures and how that's linked to music and why they focused on language per se. I don't know if that was well explained. But I'll do some heresy, being a clinical epidemiologist, to raise, I guess maybe it's a bit of a controversy or point of disagreement with some of these lifestyle interventions. I mean, we all want good studies that will clarify for us if these lifestyle interventions are effective and to what extent. But I think we all support the notion of social and mental engagement in people with dementia with very little downside. So that you start asking questions. If you're going to arrange for people like this to have activities, is there a reason that you wouldn't want to use music as at least one of the things that you'd expose them to? And there's just a certain, I guess, common sense. Music is something that connects to a lot of people. So the rationale behind it, I think, is hard to disagree with. So you start getting into these disagreements, and even at some of the dementia meetings where they have people getting together trying to, I guess, discuss whether we need randomized trials for everything that we do. And it's a difficult question, right? Because my purist background would suggest without those kinds of trials, it's going to be very hard to say with any certainty that these treatments have benefits. So I just think it's an interesting discussion because
totally. They mentioned, the authors mentioned really briefly in the introduction of this, that there's some scholars argue that there's really no benefit, there's not enough like quality studies done that show that music actually is doing something here, but many people use it. It's very widely discussed because it's very socially popular, like what's the harm in music kind of thing. I think it's just like interesting in terms of funding, like in a real type of level, when you're talking to people, if you have a certain budget and there's discussions about how to use it. I mean, we don't have a lot of quality studies about this, but it's the technology used to bring music into some of like our long-term care facilities. It can cost a lot of money. So if you can have something to say like, this works, it's like it's a definitive improvement in this costs all this, you can make a better case for it, but it's relatively inexpensive at home and other places.
So thank you. Being mindful of the time, just after 9 o'clock, thank you very much, Dr. Majeed, for a great first presentation and excellent discussion. By way of announcements, please remember all to complete your evaluations. The link was sent during the hour. And upcoming events,